All right, everybody, welcome to week 2 of our course. This week, we are covering diagnosis and treatment. Quick housekeeping. I know that many of you work and you are managing and juggling and navigating multiple roles in your life. So if you need an extra day or two on your initial post for the discussions each week, that is totally fine. Ivy and I are happy to give you a day or two additional to post. The only thing that we really don't have flexibility with is like your response. So if you don't post within the week, we don't have authority to give an extension. That's something that's built into Canvas that we don't have the ability to override. So if you can have your initial post done by day 5 of the week, and then your response posts, so you only need 2, not 3, by the deadline of day 7 of the week, that would work. As always, my office hours or Ivy's office hours are Wednesdays from 8 to 9 and mine AM, and my office hours are Wednesdays from 7 to 8 PM. All right, let's get into it. So first, talking about the DSM. So not to hopefully frustrate anyone, the DSM-5 text revised is going to be released in March. So that does not make what you're learning in this class moot, null or void, or anything like that. It just you happen to be taking a course that is talking about the DSM when the DSM is releasing a new edition. So we will see what is different, and I will do my best to incorporate that into this class. But for now, we are working with a DSM-5. So the DSM, as I mentioned this last week, is organized through both developmental, it has developmental considerations, and is organized for diagnoses that you will see kind of chronologically as they come out through the lifespan. So as noted here in the second point, it's organized to reflect the processes that manifest earlier. So the earlier chapters in the book talk about like neurodevelopmental diagnoses that would happen in adolescence or even before that, childhood and adolescence, and then followed by diagnoses that would happen in young adulthood, things like bipolar, depressive. We'll learn more about that, but those are things that are going to happen between 18 and 25. And then diagnoses you'll see commonly later on in life, things like neurocognitive disorders, things like Alzheimer's, dementia, stuff like that. So the whole book is organized that way, and then the chapters are also organized that way. So if you are looking at something like personality disorders, you're going to see that is also organized in a developmental and lifespan way. So this is meant to help you. It's meant to aid you in decision making as you're going down that decision tree. So a lot of what we learned about this week is considering culture. So just really, again, I mentioned this last week, but really understanding that the DSM is a culturally bound book. So it is informed by research. Our research is informed by the people who conduct it, by the people who participate in it. And they are also culturally bound. So the way that we understand and conceptualize mental health is culturally bound. So the way that we define suffering, the way that we define what health is, what is normative in our own sense. These things are all culturally bound. So it's just very important to expand your view beyond yourself and recognize what you see and what you have come to learn as, quote, healthy, quote, normal, quote, dysfunctional and functional, and recognize that that is just one viewpoint. So when you look at, when you're working with somebody from, a different religious background than yours, a different spiritual background, and we'll talk about that more heavily in the article that we read this week, that just has, a different definition or a different conceptualization of the symptomology, that has to be taken into consideration. So culture shapes our experiences and our expression of symptoms, signs, and behaviors that can fit criteria within the DSM. So this is where that, we're not looking at the DSM as prescriptive, it is descriptive. And it's more than just a checklist of going through the inclusion criteria. You have to take the time to talk to your clients. And if you are working at an agency or working in a setting that doesn't allow for you to take time, we'll talk about how to navigate that a little bit later in this PowerPoint. So culture is passed down. It is, as it says here, transmitted. So it is learned from before you're born. And culture is, the people within a culture inform the culture, and the culture informs the people within it. So it's this bi-directional kind of like feedback loop in a way of how we learn and how we function. It's also informed by our social systems, our institutions. As we know, the medical institution within the United States, for example, has a very specific culture. And then it has different cultures where, like, depending upon where you work and where you practice, that's, regionally the type of setting. So culture has meanings, habits, and traditions that can absolutely exacerbate the stigma that goes along with different diagnoses. And then it also can really provide support in terms of social response to some diagnoses. So what you will find is within the DSM, this could be a conversation that you have at home where some of the diagnoses are met with a lot of compassion and a lot of patience and a lot of grace, and other diagnoses are met with like disgust and a lot of stigma and apathy or worse. So you'll see that even within the spectrum of mental health, that we really respond to different diagnoses and individuals who are experiencing the symptoms of those diagnoses very differently. And again, that's specific to the culture within the United States. And I would argue the dominant culture within the United States. And then, as we know, there are a multitude of cultures, outside of the United States, within the United States. So again, it's important to understand your client's experience of their symptoms, both positive and negative symptoms, the support that they're getting, the response that they are receiving, how that is conceptualized within their culture. All of that stuff is really important to know. Culture also can provide coping strategies that can enhance resilience, and the culture, the person's cultural background also may have, there may be other options for an individual who is struggling with mental health diagnosis, where they're not seeking, quote, traditional healthcare. They could be going to a more traditional healer. They could be participating in rituals. And just because these aren't, quote, westernized, and just because this may be something that you wouldn't do, that you may, if you have a medical issue, you're going to a medical doctor or somebody who is trained within, traditionally trained. And I know you guys can't see me, but I'm doing a bunch of air quotes over here, within the medical system. And that's just not what is the most helpful to everybody. And that's just not what everybody believes in. So being open to what we, and I say that as, people taking this class, who are learning within the medical model in specifically within the DSM, what we would consider alternative or complementary healthcare options. So some more considerations. Culture absolutely influences the acceptance or rejection of diagnoses, and how and or if the client is going to adhere to any treatments, which absolutely can affect the course of recovery. So again, this is where you need to be open to what would be considered alternative or complementary options. Just really seeing, so how is illness defined? How is it treated? Where are some places that when people are feeling sick, who do they go to? What do they do? So seeing like the hospital isn't the only option, an inpatient setting isn't the only option. So again, just being open to that. Culture affects the conduct of the clinical encounter. So if there are big cultural differences, or really it can be subtle cultural differences between you and your patient or client, so that we use patient or client depending upon the setting that we're in. Usually if we're in hospital settings, we say patient. If we are in more outpatient or private practice or agency, we call the person that we work with a client. This will have implications for the accuracy and acceptance of the diagnosis. And the reason it affects the accuracy is because you may not be getting full information from your client. They may not feel comfortable with you. They may filter because they don't want to share or don't feel comfortable sharing. So the more that you can position yourself and present yourself as open to all possibilities, open to all ways of healing, all ways of conducting, the better you will be in this. Also the acceptance of the diagnosis. So again, if you are coming from a traditional background in medicine, where, again, maybe you're working in a hospital, it may feel too sterile, it may feel too westernized for an individual, too medical, too just, again, too prescriptive. So just really, again, having these conversations where you are understanding the client's experience. So when you are assessing, you have to take into consideration the individual's experiences, symptoms, and behaviors, and how they may, be an aberration from sociocultural norms, and how that is affecting the individual, but also understanding, the broader sociocultural context, their specific, community, their specific family, that individual. So it's like, culture is kind of like Russian nesting dolls, where we have the, large dominant culture, dominant discourses, that can be very destructive, but everybody kind of, buys in a certain way. It doesn't, the dominant culture doesn't really let you not buy in. But then we have all of these cultures that are nested within that. So really trying to unpack as much of those as you can as you're going through the assessment. So the DSM does include cultural considerations in each of the diagnoses. So these are important pieces of information for you to get familiarized with, not only in the DSM-5, but also in the DSM-5 text revised. So going back to, I mentioned this last week, of the other specified and unspecified disorders. So within the DSM-5, every single diagnosis has the option for an other specified and unspecified kind of like qualifier. So the other specified is provided to allow you to communicate the reason why you chose this diagnosis and did a differential diagnosis of this. And why it does not meet the criteria for any other category within a diagnostic class. So this would just be additional information that you would be adding. So this would be where you are saying like, it's not this for like a very short reason. And then so you have the option to do that. Neither of these are necessary, but it's like kind of to help you. It can be, an assessment kind of along the way where you are, trying to like, maybe help future clinicians or help your future self or help the client to understand and have that in writing, help insurance companies understand why you chose the diagnosis that you did. And then you can also choose to not specify the reason that the criteria are not met for a specific disorder. So then you would have unspecified like anxiety disorder, unspecified depressive disorder that would be diagnosed. But the differentiation between these two is really, it's your choice. So it's allowing you to add other information with the other specified or not to add any information with the unspecified. And so it allows you flexibility. This is also, it's not even necessarily about not having enough or not wanting to. Sometimes you don't have enough information. And sometimes this is an opportunity for you to kind of like extend the window of assessment. So you can also use it to give yourself more time to come up with a diagnosis that feels like you've had enough time to accurately assess it. So that's, again, they're meant for maximum flexibility with the diagnosis. Also recognizing that not everybody fits the criteria perfectly. So the DSM-5 includes some online tools for you. So it does, the book itself is nearly 1,000 pages, but it does offer some assessment help for you, or some, assessment support, supplementary kind of content for you at psychiatry.org / I actually don't, I think that's just DSM-5. And it gives you connection to the relevant diagnoses with that. And then there also is so there's 2 forms of the cultural formulation interview. The one that the individual fills out, and then, or the one that you fill out, and then the one that informants fill out. These are, family members, friends. These are individuals close to the person you're working with. So again, it's very important to get consent for that. So it doesn't feel like, this was something done behind their back. So you always want to have this very trusting, open relationship with your clients. So that's found at the same place. So psychiatry.org / DSM-5, please feel free to go check that out. So using the DSM, when you are formulating a case, which really just means how you are conceptualizing the case, how you are understanding the individual in their context, it has to have a clinical history. So this is that biopsychosocial, and it's, that's been extended to the spiritual piece, but, I'm sure all of you have heard, or at least mentioned, the biopsychosocial model, where you are understanding the biological factors that have contributed to any sort of mental health disorder. So for example, we know that, substance use disorder, there is a genetic component to that. Psychologically, what's going on with the individual? Have they had, a recent large change in their life? Do they have, some kind of stress or some kind of family conflict, something that is going on that is affecting, how they are coping with that? And then socially, I guess I just kind of mentioned a couple of social ones of, this is more interpersonal, and can be larger in the, socioecological model, what we would consider more like macro level or even potentially meso level factors. So as I mentioned before, it's not sufficient to just get like a checklist of symptoms and be like, have you been having this thing for 6 months? Okay, check. Have you been, has your functioning been affected? Okay, check. And not asking any other like follow-ups or getting to know the client at all. So really, when you are doing the case formulation and you're and you're understanding the individual within their context and how that affects their mental health and all that kind of stuff, you want to use any and all contextual and diagnostic information. So the contextual information is that interview, is getting to know the human, and then the diagnostic information is as you are going through the DSM that it is best practice to go through that with your client. So it sounds like, you're experiencing some kind of depressive disorder. Let's go to that section of the DSM and let's understand. So you're using some of your clinical expertise to kind of, like navigate the process of finding the appropriate diagnosis a little bit more quickly because you have like a working understanding of what what the inclusion criteria is for each of these. But then you're working, sorry, it's young. But then you're working with the client to have them help you, like help each other fill in the gaps. And again, this is informed by their cultural and social context. So these are broad elements that are required for any sort of mental health diagnosis. So the person who is experiencing the diagnosis or the disorder has to have a clinically significant disturbance. And then, so again, remember, clinically significant is subjective. There's not really like a formula for it. You can't really quantify it. This is where you're working with your client. Like, is this affecting you in a way that like brought you here? Or because some people don't come voluntarily, but you're really trying to understand, like, is this person able to function? So clinically significant disturbance in the individual's cognition, emotional regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes understanding or underlying their mental functioning. So this is where you are using some of your clinical judgment. This is where you are working with the client to understand that. So are they experiencing distress or any sort of disability in their social, occupational, or any sort of other important activities? So this is where you're understanding, prior to the onset of your symptoms, what was your life like? How has it changed? Has it changed? So an expectable or culturally approved response to a common stressor. So for example, like I know in some religions, I'm not sure, I'm going to expose some of my ignorance here. But I think, is it Judaism where there's like a kind of like a required mourning? I don't know if it's required. But when somebody dies, that there's like a week period where it is pretty much, it's like dedicated to the mourning of this individual. So please, if you guys want to, post into discussion or shoot me an email and let me know if I'm, mistaken on this. Whereas potentially in other religions or in other cultures, that could be seen as, like significant bereavement or something like that. Or if there are, rituals being conducted with about an individual where, that would get side-eyed in certain cultures where there would be, maybe questioning if there's some delusions or hallucinations that are going on or something like that. So again, really making sure that this is expectable and culturally kind of normative within where the person is seated. So if there are any socially deviant behavior and conflicts that are primarily between the individual and society, that these are not mental health disorders unless the deviance or conflict results from dysfunction within the individual as described by the other things that we have covered. So socially deviant behavior, you know, what is dubbed legal doesn't necessarily mean that if you break that is a mental health disorder. So if it is dubbed, you know, something by the Supreme Court that is now in action or something, and that person goes against it, that doesn't mean that it's socially deviant in that way. So just making sure that, you know, just because this person enjoys some kind of kink or something like that does not mean that that meets criteria for any sort of diagnosis. You know, I think sexuality is an area where as an, I guess, American culture, because that's the one that I'm most familiar with, you know, it's like we're simultaneously over sexualized and sexually repressed. So the messaging is very mixed. So, you know, sexual deviance is what you could probably find it like somebody who considers everything or certain subgroups that, you know, consider everything socially deviant. So it really depends upon the circles that you run in about this. But anyway, that's some place where I would go in a completely different lecture. So some notes about diagnosis and the use of the DSM. So diagnosis is meant to have clinical utility. So it should help you to determine the prognosis. So like, what can the client expect? You know, what duration, severity, you know, what can they, based on the symptoms that they're experiencing and the you know, consequential diagnosis that they receive, how well can they do? Treatment plans and any other potential treatment outcomes for your clients or patients. This is not, but just because somebody has a diagnosis, so let's say you go through assessment and you come to the conclusion, you know, with the consultation and collaboration with your client, that they have a diagnosis, that doesn't mean they need treatment. So treatment is very complex. So some things that you should consider are symptom severity, symptom salience. So these are things like the presence of suicidal ideation. How distressed is the client about this? Because I always think that, you know, sexual disorders are some of the best examples of this, where, you know, maybe you have somebody who is experiencing erectile dysfunction or anorgasmia or something like that. And if that person isn't sexually active or like doesn't really care, that doesn't mean that they need intervention. Like that should be a consideration when you are figuring out your treatment plan. The association with symptoms, or the patient's distress associated with the symptoms. So that's what I was just talking about, disability related to their symptoms, and risks and benefits. Risks and benefits of the available treatment. So for example, if like electroconvulsive therapy is the only option for something, and the you know, potential consequences of that are like memory loss or whatever, that the client may not be willing to go through that. I mean, I think of this in terms of the medical world of somebody who has been diagnosed with cancer, where, you know, they have to undergo chemo that affects the entire body, and may not prolong life, and absolutely affects the quality of life. So, you know, just because you get a diagnosis of cancer, for example, doesn't mean that the individual is willing to go through treatment. And a lot of the pressure for treatment comes from outside places. So just really making sure that you are taking all of this stuff into consideration. You might also encounter individuals whose symptoms don't meet full criteria for any sort of diagnosis, but they really have a clear demonstration for treatment. So, and they they need it so that, again, you don't need a diagnosis to be able to treat. But what we know is our field is heavily influenced by the insurance companies. So sometimes you do need a diagnosis just on paper. And this is something that I am always incredibly transparent with clients about, of like, this is a necessity. This isn't going on a permanent record anywhere. If you were to end treatment with me and go elsewhere, just sign a release and I will explain what your diagnosis is. So just make sure that you have those conversations with your clients. The fact that some individuals do not show all symptoms indicative of a diagnosis should not be used to justify limiting their access to appropriate care. So that's just another note that, yes, we kind of live by the rules of insurance, but make sure that you're also ethical with what you're doing. So provisional diagnosis, just another note here is that it's kind of it can be a placeholder, function as a placeholder, where there is the specifier provisional, like a provisional diagnosis of blah. And again, it's the main purpose of this is to allow you more time to get enough information for a thorough diagnosis, a thorough assessment for an appropriate diagnosis. So sometimes, especially, so in my master's, my placement was in an adolescent partial hospitalization program. It was inpatient as well. We had like 24 hours to diagnose our kiddos who came in there, 11 to 17-year-olds, our adolescents. And we had to get approval from insurance companies for them to be able to stay with us. So unfortunately, when I was in my master's, we didn't have the DSM-5. I was working on the DSM-4 text revised. So this wasn't an option for us, but this would have been helpful to be able to take some time, because when our kids got into the unit, their entire first day was just assessments, the MMPI, all kinds of different hours and hours worth of assessments for them to be able to get a diagnosis. And then once they were diagnosed with something, it was very rare that it changed. So there was some rigidity in that. But again, so if they don't meet full criteria for something, but you've got a hunch, or, you need to have something down on paper, this is usually accepted for a limited time by insurance companies. So then moving on to our France's text. So he gives a few pieces of information about the diagnostic interview and about just, the diagnostic process. So many things that I've already mentioned before, but so here are just some keys to this, of the stance, the position that you take. So make sure that you're like understanding the human, and you are meeting this person as a human being, not just as this like potential diagnosis. So you are working on your therapeutic alliance first. Making the diagnosis a team effort, like I said before, of this should be a collaborative process, where as you're like literally reading off the criteria for a specific diagnosis, that you're asking the client, does this resonate with you? Is this an experience that you've had? You do have to, of course, go through criteria, right? So there is a bit of a quote, like checking of a box in this process, but you are asking like these conversational, open-ended questions as you are going through the criteria. So instead of, do you experience this thing? That is a close-ended question. A close-ended question is a question that can be answered with a yes or no response. Open-ended questions have, they can't be answered that way. These are questions that start with how, what, when, in what fashion, can you describe, these types of cues for that individual. So if the diagnostic is experiencing this thing, It can be, have you experienced this thing? And if so, tell me about that time. Give me some sensory details about what was going on. You want to use the screening questions. So again, every single diagnosis has kind of like has a decision tree connected to it. So as you are asking the screening questions, let's say, for example, that you get to, again, I know I always use schizophrenia, but delusions and hallucinations are pretty, specific to schizophrenia, obviously depending upon substance use and stuff like that, because you can have acute kind of psychotic episodes with certain things. But anyway, so let's say you get to asking about like hallucinations and they don't have any. You're not going to keep going down the route of schizophrenia. You're going to use that as a option or as information to move on. Or if they start to really describe, some depressive symptoms, you're going to stay in that lane. So you're navigating the screening questions in a way that doesn't make it unnecessary. I'm trying to think of not the OQ45, that's different. In the university that I last taught at, we used the mini, I forget what it stands for, but our students were required to go through every single question, obviously for training purposes, but in real world application, that's something where it's clear this person isn't indicating anything in this area, move on. That's essentially what it's saying here, is trying to navigate that process so that you're not asking this person unnecessary questions that you already know the answers to, but you're just going through it for the sake of going through every single question. So using some clinical judgment there to make the assessment process as painless as possible, because it can get pretty drawn out. Again, remember the significance of clinical significance. So just again, making sure that you're understanding the client's perspective on this, their level of distress, your understanding, severity, duration, all of those things to come to a, consensus about the appropriateness for things like treatment. And then testing your subjective judgments. So just always being aware that we have biases, we have judgments, we have preconceived notions, we have stereotypes, we have internalized stuff going on within us. So if you're finding, these are always, it's never, when any of these like thoughts come up, it's never a time to like judge yourself for it or to, recoil in shame and not talk to anybody about it. It really is just, it's for you to be aware of and for you, but you to work through. So it's not like oh yes, I, grew up in a very homophobic family and that's just how I think. That's okay. I just need to be aware of it. No, it's not just be aware of it. It's also working through it in a way that allows for you to see humanity. And for that, like the goal is to decrease and ultimately eliminate these isms, these phobias. But just making sure that you're staying constantly critical of yourself, constructively critical of yourself in, okay, like, where does this come from? Oh, I felt reactive to this client. What was that about? Let me talk to people about that. So it is very important to create a professional circle that provides space and a non-judgmental, very open, warm, accepting space for us to work through our biases. Because especially they are absolutely vilified in this field. Like if you come in and say something like, I just don't really understand trans people. That would not be met with a lot of patience in our field. Quite frankly, that's grounds many times for reporting, for fear that you are going to do harm. But in certain settings, for anybody who is like, shit, that's me, please don't be alarmed. These are things that I think Alliant in particular is very good about providing space for this. But it does depend on your attitude. So I just say that to start to, if you haven't already, practice this questioning of your responses, your reactions, your thoughts, where you learned what you know, how you learned what you know, just being very constructively critical of that. So there, Francis proposes a step diagnosis, not a whole lot different than what we learned last week in differential diagnosis. You can see that steps 1 through 3 are a little bit different. 6 is actually different as well. But the first step is engaging in a watchful waiting. He recognizes, he does know, like, not all settings allow for this. Like, you have to work under the provisions and protocols of the agency or wherever you are working. But the underdiagnosing or waiting is better than diagnosing quickly without full information. So make sure that the symptoms are severe and persistent enough to count. So for example, if somebody, like, again, I always think of bereavement, where it's been, a week since the person died and they haven't been able to get out of bed. There is, in the DSM-5 text revised coming out, there is a diagnosis on bereavement, but you wouldn't have like sufficient time to say anything about this. A week is not enough time of symptoms to diagnose anything. So when you are going through the diagnosis and the inclusion criteria and stuff, making sure that you're really educating the client on what you're talking about. You're normalizing some of the reactions to it, normalizing the behaviors, things like that, and reassuring them that, this is treatable. You're going to be okay. This is something that can be worked through. Just really making sure that they feel as comfortable and not stigmatized and not dehumanized as possible. Ruling out the role of substances, like I said before, as we know, some psychotic features can be potentiated by use of substances or the withdrawal from substances. So just making sure that you're understanding what role that substances play, ruling out the role of any sort of medical illness. So we know that this is kind of a bi-directional relationship where there can be, anxiety caused neurologically by something that's going on medically, or like the knowledge of this medical diagnosis can create or contribute to anxiety. That, for example, but just really, again, doing that differential diagnosis piece, and then ruling out bipolar and depressive disorders in whatever other symptoms you are seeing. So here are some tips that Francis provides. I think these are really helpful. So again, knowing the person is important. Just as important as knowing the criteria and stuff like that, you want to get to know them. Take time, again, slow down. If you're able to do this within your setting. I loved this analogy. If you hear hoofbeats on Broadway, think horses, not zebras. So don't pick like this really exotic kind of rare diagnosis. It's usually a rare diagnosis for a reason. Getting all the information that you can. Can be from the individual. These can be from informants with the individual's consent. Understand and consider previous diagnoses for this individual, but don't just carry them over. So you want to be critical of these previous diagnoses, because as we know, they can ebb and flow. They can be periodic. They can, happen at some developmental stage and then they're no longer relevant, no longer happening. So, unfortunately, I see this a lot with adults who are like in their 30s and 40s where they were diagnosed with something at like 15. And now they're like, oh yeah, I was diagnosed with this 25 years ago and I've never been reassessed, or all of my providers just kind of believe that this is what I have. I do not believe that that's best practice, but there are constraints to all of that, usually with resources, money, time. Constantly revisiting the diagnosis, again, always making sure that it's relevant. This is very similar to your treatment plan. What you'll find if you haven't had this class yet, is once you build a treatment plan, it is a living document. So it could change week to week, but it really is, it's essentially kind of a roadmap. So if any piece of it is irrelevant, a piece of your roadmap is irrelevant. So the diagnosis needs to be constantly looked at, making sure that it still fits the, whatever symptoms and whatever things that the individual is experiencing. Just notes that children, teenagers, and elderly individuals are difficult to diagnose. That's where some of the lifespan and developmental information within the DSM was meant to try to be helpful in that. If the presentation of a diagnosis is less severe, it's going to be more difficult to diagnose. So again, it's just giving yourself grace and patience to make sure that you're gathering all the information. As mentioned before, when it's safer to underdiagnose than to just slap a label on somebody. Accurate diagnosis can bring great benefits. Inaccurate diagnosis can be a disaster. And then finally, just remembering to do no harm. So, if the individual needs resources, provide them to them. If you are unsure of something, don't slap a label. Take time to get to know the individual. So I am not going to necessarily say much about this, but just to remind you to look at these things. So as we saw, there are many cultural concepts of distress that may not be here, like known in the dominant culture here in the US. But it's this glossary of cultural concepts of distress provides a description of some of these syndromes, idioms of distress, and causal explanations relevant to clinical practice. So for example, the first one that we read about was ataque de nervios, where, that translates in English to attack of the nerves, which can be diagnosed. Well, which again, this, just because it's a nerves attack or an attack of the nerves doesn't mean that it's that's a panic attack, because it's not only the saying, but it's the understanding of it, the cultural conceptualization. Again, these idioms of distress, these explanations where I know that we had one, I forget what it was, but where it's basically translates to like fright. And it's when, your soul leaves your body, where we may, from a kind of a diagnostic, dominant culture lens say, oh, this is this, but there's no equivalent to, like, there's no diagnostic criteria, or there's no inclusion criteria that says like your spirit or your soul leaving your body. So it's just very important to be aware of these, and quite frankly, consult with clinicians who practice or who have experience within the culture and can do some kind of like translation in a way of making sure that the way that it is being treated by somebody who thinks within the dominant culture still can be culturally concordant to the individual who is being diagnosed. So again, Dr. Francis, he's the one who wrote our Essentials of Psychiatric Diagnosis, where I was just talking about this a few slides ago. He wrote an article about the debate over the DSM-5. Again, as we read, so he was on the board for the DSM, I believe the DSM-4, the DSM-4 text revised, maybe even the DSM-3. But basically his stance on this. So it's always important to see all sides of a debate when it comes to mental health. I don't necessarily think that this is appropriate in all realms. But just making sure that, so his overarching belief is that this is too broad. The criteria now are, it's almost like a net that's been cast that's too large. So there's going to be, this can result in overdiagnoses. So why does he believe we diagnose? So again, I think a lot of things boil down to money. But the DSM-3 that was put out by the APA. So remember, the DSM makes money. The APA, the American Psychological Association, makes millions and millions of dollars with the publication and purchasing of the DSM. So it became a bestseller. And so this started with the DSM-3. This is where diagnoses kind of blew up, where like in the original DSM, there were like, I don't know, double digit diagnoses, and then it went to triple digit. Now we're in very high triple digit. So it just keeps kind of, times X increasing in the number of diagnoses. So it became a bestseller, was well known. It was in, it affected decisions in many arenas. So now we're in a place where diagnosis is needed for a lot of stuff. Also with the pharmaceutical companies, Prozac was being prescribed. The pharmaceutical companies and clinicians kind of, in bed together for profit. So if you get a kickback from prescribing a medication, and that medication needs a diagnosis, you're going to be diagnosing that thing. Insurance companies now require that doctors give a diagnosis if they want to get paid for the visit. So that absolutely has an influence on diagnoses, and drug companies that they recognize that there are fewer psychiatrists than there is like potential for making money with prescriptions. So let's give primary care physicians who didn't specialize in diagnosis, they didn't specialize in mental health or, the brain chemistry, neurotransmitters, kind of stuff like that. But they also have the ability to diagnose and prescribe. So again, this is, maybe a bit of a jaded view on this, but I also believe that there's absolutely some reality to it. So again, this isn't meant to be like a knock on anything. It is just understanding our history and understanding the context of diagnosis. So some advice are very similar to what we've read is take your time. Sometimes diagnosis can't be done in 7 minutes, which happens, right? So if you're even with a psychiatrist, your sessions are 20 minutes. You're given something pretty quick, or you're asked a handful of questions and then you're given a diagnosis. Many times diagnosis can't happen appropriately and correctly, accurately in one meeting. But again, in the care model that we are in, you're not always allowed the time. So when you're in doubt, wait, watch, provide support, normalize the situation, see if there's other like resources that can help the client, and then hold off on that. Again, you may be working in a space where you have to have a diagnosis. That's where that provisional diagnosis can be helpful. And understanding the environmental factors is incredibly important with diagnosis. So then moving on to the article on how our society breeds anxiety, depression, and dysfunction. So again, this is just really taking into consideration and having us take a, zoom out on the environmental factors that can be at play when we have an individual step into our office or into our space. So the article notes a few potential contributors to this, that, as a society, we are more disengaged from our jobs and our schooling. That you were provided some statistics on this. So again, this can affect things like purpose, meaning, motivation, sense of self, sense of worth, which are all topics that we deal with as mental health professionals. For maybe the fellow millennials out there, we were sold the message, get a education. It'll be the key to unlock all kinds of stuff. And what millennials are finding particularly, I think we were the ones that were kind of first hit by this. That's not exactly how it panned out. So we're pressured to accrue increasingly large student debt. And then we need these credentials to get jobs that we don't like, or that there's little availability, or the pay is not what we expected, things like that. So that can be pretty disenchanting, kind of feeling, you can feel kind of disenfranchised with that. And then, this article was written before COVID, but this last piece is, way more relevant, but increasing numbers of people are feeling socially isolated. I think there was a statistic of like 10% of people that were surveyed, which again, I don't know who they surveyed, where they did it, how they came up with their, sample or anything, but 10% of people had no confidants. And that's, as humans are, we are wired for connection and we are social creatures. That can absolutely destroy one's, again, sense of self, sense of connection, sense of humanness. So this could be one of the contributing factors. And that was it. That was mostly what I wanted to cover in that article. And then finally, psychosis or spiritual emergency, the potential of developmental psychopathology for differential diagnosis. So again, this was a very culturally informed article that, again, it's important to just really broaden your view of what could be what you're seeing in your office. So all models used to conceptualize the human experience are inherently bound in the context from which they are derived. So all frameworks that we use are inherently incomplete and limited just because it's one model. So we have to have a integrative approach. Also, the medical model is dominant, is particularly with diagnosis. In the classical medical model, psychological disorders are believed to be discrete states arriving from pathogenic and endogenous processes. Endogenous is like internal triggers, essentially. So although environmental factors may be considered to play a role, the essential nature within the medical model is seen to be more organic. So it just really, that's where our specialization comes in and is very important, where we're broadening that scope from intrapersonal to interpersonal and even transpersonal. There is little empirical evidence supporting the assumption that the classic medical model is inherently correct or complete. So we're just following this thing that doesn't necessarily have support behind it. The DSM is atheoretical. It does not follow any sort of theory of human behavior. So that can be limiting in its diagnostic sensitivity because it's not considering broader contextual and developmental factors. So again, if it's rooted in the intrapersonal, it's not going to be looking at things like culture. So the DSM classification relies too heavily on descriptive, symptom-based approach, and that implies that some kinds of clinical data are irrelevant. So, data points, meaning those environmental factors, those spiritual, contextual, cultural things, like, nah, we don't need to know that stuff. We're just going to go with the organic approach, or the organic perspective, and that can be limiting and inaccurate. So application of differential diagnosis, this is the proposed approach I'm like, why does it say or? Of developmental psychopathology and transpersonal psychology. So transpersonal means beyond the person. So the authors of this are proposing a holistic developmental model that incorporates biological, psychological, sociocultural, and transpersonal, which I think you could argue could be spiritual factors, that can afford the clinician a more like subtle framework, so that there are multiple data points that are being considered. The developmental lens contends that psychotic disorders do not simply emerge spontaneously. So again, this is where you are, how we traditionally do this. This is where you are adding in that historical interview, where you're doing an interview, so you're getting a larger, more robust, rich picture of the individual. And then again, as always, if you ever have something that is accompanied by like hallucinations or delusions, where if you're looking at it from a symptom-based view, where you would label it that, really make sure that you're looking for substance use and the timeline of those substances. So remember, it can be in an active period of intoxication. This can happen in withdrawal. So really just making sure that you're looking at the substance use. And that is it.